Hello everyone, this is Dr. Abhishek and I am present here to give a brief overview of heat related illnesses. As we all know that mercury has been rising this summer and we are all experiencing scorching heat. So the today's topic is very conducive as per the situation. If we see the spectrum of heat related illnesses, there are two categorizations. First is the direct effect of heat. We will cover it one by one. First is the sunburn. Second is the prickly heat, which is also called Miliaria rubra or Lichen tropicus. And third is the heat edema. Secondly, if we see the systemic effects of heat, it will be covered under heat cramps, heat tetany, heat exhaustion, and heat stroke, which is life threatening. First, we will discuss the sunburns. It is caused by overexposure to UV light. As we all know that there are three types of UV rays: UVA, UVB and UVC, out of which UVA is most penetrating. It reaches up to the level of dermis, while UVA reaches the stratum corneum and the epidermis. UVC is mostly absorbed by the ozone layer. So the maximum damage is caused by UVB and also UVA. So sunburn is caused by overexposure to UV light, primarily UVB radiation, which is in the range of 280 to 320 nanometers. Clinical features of sunburn include painful redness, warm and tender skin, burning sensation, swelling and edema, blister formation, and peeling and desquamation often occurs after 3 to 7 days. Now, how to manage sunburns? Move out of the heat immediately. Then put cool clothes on the sunburn areas or take a cool bath. Drink plenty of water. Apply moisturizer like aloe vera gel, calamine lotion. Don't prick the blisters and apply sunscreen with a sun protection factor greater than 30. The application should be at least 15 to 30 minutes before the sun exposure and reapplication should be done after 2 hours. Then prickly heat or heat rash, which is also called Miliaria rubra or Lichen tropicus. It is an inflammatory skin condition caused by blockage of the sweat ducts. The clinical features include multiple small erythematous papules or papillovesicles. Then there is intense prickling, stinging or itching sensation which becomes worse with sweating. The common sites of predilection are the sites where there are abundance of sweat glands like the neck, upper chest, upper back, armpits, groin and other skin folds. Treatment again include moving to a cool, well ventilated or air conditioned environment, wearing loose fitting cotton garments, avoid tight occlusive synthetic garments, take cool showers or baths, keep the affected areas dry. Calamine and lactocalamine lotion should be applied, then cold compresses may relieve discomfort and oral antihistaminics may be used if it is associated with itching. Now heat edema. Heat edema is caused due to cutaneous vasodilatation and orthostatic pooling of interstitial fluid in the extremities, and it is most commonly found in elderly individuals or those individuals who are non-acclimatized. The treatment again includes moving to a cooler environment, elevating the legs, walking periodically and avoid prolonged standing, and maintain adequate hydration. It will require further diagnosis if it is the edema is associated with unilateral swelling or a calf pain, then dyspnea, chest pain, tenderness, skin discoloration. So if these features are available, so heat edema should be further investigated. Heat cramps are again painful spasmodic contractions of the skeletal muscles, usually seen after a heavy exercise or after a latent period of sweating in high heat. Common in non-acclimatized individuals, it commonly affects the calf muscles, the thighs, the hamstrings, the abdominal muscles, the shoulders, and the arms. The pathophysiology include heavy sweating and loss of sodium and fluids, which lead to inadequate electrolyte replacement. This causes muscle fatigue from prolonged exertion, and this leads to increased neuromuscular excitability. Treatment again include rest and rehydration with water and electrolytes. Now we come to discuss the more severe effects of heat. First we will discuss the heat tetany. It is a heat related condition characterized by hyperventilation, tingling sensations, and painful muscle spasms, particularly of the hands and feet, and it is usually caused by respiratory alkalosis from hyperventilation. If we see the basic pathophysiology, hyperventilation causes increased CO2 washout. So this causes respiratory alkalosis, hypocalcemia progressing to tetany. Now, how does hyperventilation and CO2 washout causes respiratory alkalosis and hypocalcemia? We will see in the next slide. Now, as we all know that CO2 in the blood combines with water to form bicarbonate, and this bicarbonate breaks into hydrogen ions and bicarbonate ions. So now when a person hyperventilates, so excessive breathing will remove CO2 from the lungs. So CO2 washout will happen. Blood PaCO2 level will fall. So definitely more hydrogen ions will be consumed to produce CO2. So the equilibrium reaction will shift to the left. So more hydrogen ions are consumed means lesser hydrogen ions will be available. So definitely the blood pH level will increase. This causes respiratory alkalosis. Now this alkalosis increases the binding of calcium to albumin. Since protein binding of calcium increases, so ionized calcium level decrease. So this leads to neuromuscular hyperexcitability, which causes tingling, paresthesia, carpopedal spasms, and this thing can be explained by Henderson-Hasselbalch equation also. Since in hyperventilation there is carbon dioxide washout, so PaCO2 level will decrease. Since PaCO2 in the above equation is in the denominator and the denominator is decreasing, so the fraction will overall increase and thus pH will increase. This leads to respiratory alkalosis. The symptoms of heat tetany include circumoral tingling, which is the tingling around the mouth. Then tingling also occurs around the fingers and the toes. Dizziness, anxiety, and rapid breathing is there. Signs include carpopedal spasm. This is a characteristic sign of heat tetany. The carpopedal spasm means there is wrist flexion, then metacarpophalangeal joint flexion is there, then extension of the interphalangeal joint is there, and thumb is adducted into the palm. So these four features combined, it is called carpopedal spasm or obstetrician's hand. Then muscle twitchings will be available, hand and foot cramps can be seen, and positive Chvostek sign. If we tap the facial nerve near the ear, so there will be twitching of the facial muscles, which can be seen at the corners of the mouth, at the nose, the eyelids, and the lip. The management of heat tetany include removal from heat. Then patient is made to breathe his or her own expired air through a rebreathing mask, and IV injection of calcium gluconate 10 ml of 10% slow infusion over 10 minutes. Now before we go into the details of heat exhaustion and heat stroke, it is important to know about the body temperature regulation. As we all know that humans are warm blooded animals, we are homeothermos. So this means that a core body temperature is maintained despite large fluctuations in external temperature. So internal temperature must be maintained for the body to function normally. If the body temperature gets too high or too low, it can cause serious injuries to the organs and can also cause death. In our body, hypothalamus is the thermoregulatory center. So it maintains the temperatures through the cutaneous vasodilatation and sweating. The hypothalamus, particularly the anterior hypothalamus, the preoptic area in the anterior hypothalamus acts as a heat loss center. It is activated when the body temperature rises, and through mechanisms like sweating and cutaneous vasodilatation and reduced heat production, it regulates the body temperature. Similarly, the posterior hypothalamus acts as a heat gain or conservation center. It gets activated when a body temperature falls, so initiates vasoconstriction, shivering, and increased metabolic heat production when the body temperature falls. Now let us discuss the physiological response of the body to heat. The body temperature may increase due to the metabolic processes or absorption of environmental heat. This leads to heat load. The heat load is sensed by the hypothalamus, and then the heat loss center is activated. Heat dissipation occurs through multiple mechanisms, of which the major is the evaporation, either through sweating or cutaneous vasodilatation. Other modes are conduction, convection, and radiation. Now this evaporation is the major route through which the body loses temperature. Evaporation will be ineffective when the relative humidity is above 75%. Now a question arises that why elderly people are more vulnerable to heat. This is because of the following factors. In elderly, there is reduced ability to deliver heat to the skin. Then there is reduced epidermal area available for heat transfer. Then there is impaired vasodilatation, and due to other chronic diseases, and since they are on medications, so the elderly people, they are more vulnerable to heat. Now let us discuss the physiological effects of hyperthermia. In hyperthermia, as we all know that for every degree rise in the body temperature, the cellular metabolic activity will increase significantly. So definitely the cells will consume more oxygen and more heat is generated. Body tries to meet the increased oxygen demand by deep and rapid breathing, which causes hyperapnea, and increased heart rate. Heart will pump more blood to deliver more oxygen, so that will lead to tachycardia. So clinical features will be fast pulse, rapid breathing, and palpitations. Then above 41 degrees Celsius, enzyme denaturation also happens. As we all know that most enzymes will function optimally around 37 degrees Celsius. When temperature rises beyond 41 degrees Celsius, so the protein structure begins to deform. The enzymes lose their three-dimensional shape and the metabolic reactions slow or stop. So result is cellular dysfunction, organ failure, neuronal injury. This is why heat stroke is a medical emergency. Then cytokine mediated systemic inflammatory response syndrome also occurs, because hyperthermia causes tissue injury leading to release of cytokines like TNF alpha, IL-1 and IL-6. So these inflammatory cytokines will trigger a body-wide inflammatory response similar to severe sepsis. So that's why it is often differential diagnosis. Severe sepsis has to be differentiated from heat stroke. Then there is increased production of heat stock proteins, that is chaperones. So chaperones, as we all know, that they are protective proteins produced when the cells are exposed to stress. The functions of chaperones include preventing protein misfolding. They help to repair the damaged proteins and improve cellular survival. So the HSPs are the cell's emergency repair team. Initially they are protective, but they become overwhelmed in severe hyperthermia. Now again in hyperthermia, the blood is shunted from the splanchnic circulation to the skin and the muscles. So to lose heat, body increases the blood flow to the skin. So consequently the blood supply to the intestines will decrease and the gut becomes relatively ischemic. The effects include gastrointestinal tract ischemia. Reduced oxygen delivery to the intestine causes abdominal pain and mucosal injury. So increased mucosal permeability, intestinal permeability will lead to damaged gut wall. This allows endotoxins, the bacterial products, to enter the bloodstream. So result is the further aggravation of the systemic inflammatory response syndrome leading to shock. The most sensitive tissues include the hepatocytes, that is the liver cells. It leads to elevated liver enzymes, acute hepatic dysfunction. Then vascular endothelium damage happens, capillary leakage and activation of coagulation pathways occurs. Then neural tissue are the most temperature sensitive. So the manifestations include headache, confusion, delirium, seizures and coma. The neurological dysfunction is the hallmark of heat stroke. Then in severe cases, it can also lead to multi-organ failure and disseminated intravascular coagulation. The multi-organ failure occurs due to direct heat injury, ischemia, inflammation, and the affected organs include the brain, liver, kidneys, heart, and the lungs. The disseminated intravascular coagulation, the result is the microthrombi formation, consumption of the clotting factors, bleeding tendency. The clinical signs include petechiae, bleeding, and shock. It is also pertinent to understand the classical differences between fever and hyperthermia. In fever, there is rise in body temperature due to increase in the hypothalamic set point, while in hyperthermia, the rise in body temperature is due to the failure of the heat dissipation mechanism or it is due to the excessive heat production. The causes in fever include infection, inflammation, or cytokine related pyrogen release, while in hyperthermia, it is due to the heat stroke, heat exhaustion, or malignant hyperthermia. Chills and rigor, they are common in fever while they are usually absent in hyperthermia. Fever usually responds to antipyretics, while hyperthermia there is no response to antipyretics. Temperature rarely exceeds 41 degrees Celsius in fever or pyrexia, while it often exceeds 41 degrees Celsius in hyperthermia. Treatment of fever includes antipyretics and treating the cause, while in hyperthermia it includes rapid cooling and fluid resuscitation and treating the cause. Now, after having discussed the thermoregulatory mechanism, the physiological effects of hyperthermia, as well as the differences between fever and hyperthermia, it will be easier to understand heat exhaustion and heat stroke. First of all, we will discuss heat exhaustion. Heat exhaustion is a state of cardiovascular and fluid and electrolyte depletion caused by prolonged exposure to heat. It is characterized by weakness, heavy sweating, dehydration, and the core temperature usually remains below 40 degrees Celsius. If we discuss the pathophysiology, heat exposure leads to profuse sweating, leading to loss of water and sodium. This causes dehydration and hypovolemia. Since there is hypovolemia, there is reduced venous return, leading to reduced cardiac output. Thereafter, it causes weakness, dizziness, and syncope. The clinical features are apparent, like profound weakness, fatigue, headache. Cardiovascular symptoms include tachycardia, postural hypotension, syncope, cool clammy skin, nausea, vomiting. Though there may be mild neurological symptoms like lightheadedness and irritability, but mental status remains normal, which is an important distinction from heat stroke. Now, if we discuss the types of heat exhaustion, there are two types. Water depletion heat exhaustion, there is predominant water loss, increased thirst, and hypernatremia may occur. Then salt depletion heat exhaustion means there is excessive sodium loss in the sweat. So this leads to muscle cramps, nausea, and hyponatremia. Now coming to the management of heat exhaustion, move to a cool place and rest. Then remove excessive clothing and place cool clothes on the skin, fan the skin. Give cool drinks containing salts, minerals, and sugar. If the patient is unable to take adequate oral liquids, then hospitalize for IV fluids and electrolyte replacement. Now we come to discuss the life-threatening emergency, that is the heat stroke. So heat stroke is characterized by a classical triad. The first part of the triad is core hyperthermia. Since there is failure of thermoregulatory mechanism, the body temperature rises to greater than 40 degrees Celsius. Then CNS dysfunction, it is the hallmark of heat stroke, and this distinguishes it from heat exhaustion. So CNS dysfunction may include confusion, delirium, disorientation, seizures, and coma. Then there is anhidrosis. There is failure of or absence of sweating mechanism, but this is commonly seen in classical heat stroke. In exertional heat stroke, there may be sweating. Coming to the physical examination of a patient in case of heat stroke, the general appearance of the patient is a critically ill patient, altered sensorium, confusion is there, coma, the patient may be in coma. Then agitation or collapse. Vital signs, the core temperature will be above 40 degrees Celsius, tachycardia, hypotension, there may be tachypnea and hyperventilation will be there. Then skin will generally be hot. It may be dry in uh, classical heat stroke, while there may be sweating of the skin in exertional heat stroke. The skin will have a flushed appearance. CNS symptoms will be the key to differentiate between heat stroke and heat exhaustion. There will be disorientation, slurred speech, ataxia. There may be seizures. Then CVS symptoms will be there, weak rapid pulse, hypovolemia and arrhythmia is also possible. Then respiratory symptoms include tachypnea, hyperventilation. Respiratory failure may occur in severe cases. Then multi-organ failure, as we have discussed in the physiological effects of hyperthermia. There may be multi-organ failure, acute kidney injury, oliguria, rhabdomyoglobinuria, jaundice, then disseminated intravascular coagulation and bleeding tendency due to failure of coagulation pathways. Now, differential diagnosis of heat stroke is also important because the symptoms of heat stroke may mimic other illnesses like the acute CNS infection, severe sepsis, cerebral malaria. Neuroleptic malignant syndrome may be seen in persons who are on antipsychotics, then malignant hyperthermia and thyroid storm. Now, as discussed earlier, it is important to differentiate between heat exhaustion and heat stroke. In heat exhaustion, it is due to the loss of water and salt through the sweating causing dehydration and circulatory insufficiency, but CNS dysfunction is not present. While in heat stroke there is CNS dysfunction, there is failure of thermoregulation leading to markedly elevated body temperature along with CNS dysfunction. The core body temperature in heat exhaustion is usually less than 40 degrees Celsius, while in heat stroke it is often above 41 degrees Celsius. The mental status is normal in heat exhaustion, while it is altered in heat stroke. There may be confusion, agitation, delirium, seizures and coma. Sweating, there is profuse sweating in heat exhaustion, while there is anhydrosis in heat stroke. The only exception is the exertional heat stroke where there may be sweating. We will discuss the differences between classical and exertional heat stroke in the subsequent slide. Then organ dysfunction is absent in heat exhaustion while it is present in heat stroke. There may be CNS, renal, hepatic and cardiovascular symptoms as well as disseminated intravascular coagulation. Investigations for heat exhaustion include hemoconcentration, mild blood urea nitrogen and creatinine and electrolyte abnormalities. While in heat stroke there is marked elevation of creatinine, metabolic acidosis, coagulopathy, thrombocytopenia, rhabdomyolysis, metabolic acidosis, liver and kidney injury, coagulopathy in heat stroke. The treatment of heat exhaustion includes, as discussed before, removal from heat, rest, oral and IV fluids, electrolyte replacement and cooling. While in heat stroke, it requires immediate aggressive cooling, IV fluids, manage complications and ICU care. We will discuss in the subsequent slides. Now let us understand the differences between the classical heat stroke and exertional heat stroke. If we see the target population of the classical heat stroke, or which is also called a non-exertional heat stroke, it is basically the elderly, infants and the chronically ill patients, while in exertional heat stroke it occurs in healthy individuals, the athletes and the laborers. The trigger is in classical heat stroke is high environmental heat plus humidity, while in exertional heat stroke it is usually heavy exercise and strenuous physical activity. The onset in classical heat stroke is gradual from hours to days, while in exertional heat stroke it is sudden. Sweating is usually absent in classical heat stroke. There is complete anhydrosis, while it is often present in exertional heat stroke. The body temperature, the core body temperature will be very high in classical heat stroke, and it may rise very rapidly in exertional heat stroke also. Skin is hot and dry in classical heat stroke, while it may be hot but moist initially in exertional heat stroke. CNS dysfunction is prominent in both, and it is classic of heat stroke. And CNS dysfunction is absent in heat exhaustion, which is a major difference between heat exhaustion and heat stroke. Rhabdomyolysis in classical heat stroke is less common, while it is more common and severe in exertional heat stroke. So the typical setting in classical heat stroke is heat waves, poorly ventilated rooms, while in exertional heat stroke it is usually due to strenuous physical activity, sports, military training and manual labor. Now the given flow chart shows the management principles of heat stroke. First of all, it is important to recognize the signs of heat stroke. The core body temperature is above 40 degrees Celsius or 104 degree Fahrenheit. There is altered mental status, CNS dysfunction, there is confusion, agitation, seizures and coma, and hot dry skin or profuse sweating. Hot dry skin is in classical heat stroke, while profuse sweating may be there in exertional heat stroke. If these features are present, then heat stroke is strongly suspected. So we need to take immediate action. Call for help and activate emergency response. Move patient to a cool area. Then remove or loosen excess clothing. Rapidly assess the airway, breathing and circulation. Then start cooling immediately, like evaporative cooling and all. Rapid cooling is the goal, and the core temperature, the goal should be to bring the core temperature to less than 39 degrees Celsius. So cold water immersion and alternatives like tepid water sponging, ice packs in armpits, groin and neck, and evaporative cooling should be used. Then concurrently we need to manage, we have to establish IV access, start isotonic fluid 0.9% of normal saline, then monitor pulse, BP, respiratory rate, SpO2, ECG and the core temperature. Consider giving oxygen if SpO2 falls below 94%. If there are seizures, then benzodiazepines can be used. Antipyretics are totally ineffective in heat stroke. Foley's catheter insertion can be considered to monitor urine output, and it should be accompanied by certain lab tests like CBC, electrolytes, renal function test, liver function test, coagulation tests, arterial blood gas analysis and lactate analysis. Then after all these things, reassess whether the core temperature is less than 39 degrees Celsius, mental status is improving and hemodynamically the patient is stable. If all these are yes, then stabilization and monitoring should be done. Otherwise the ongoing management needs to continue. So we have to take a stand based on the we have to keep assessing the patient and take action accordingly. And remember that heat stroke is a medical emergency, so rapid recognition and immediate calling within the first 30 minutes saves life. Now, how to prevent heat exhaustion and heat stroke? Drink plenty of cold drinks, especially while exercising. Take cool baths and showers. Wear light colored and loose clothing. Sprinkle water over the skin and the clothes. Now the sun should be avoided, specifically between 10 a.m. and 4 p.m. Use goggles and umbrella if it is specifically necessary to go out, and stay in shades as much as possible. Alcohol should be avoided, and extreme exercise and extreme strenuous activity should also be avoided. And do not ignore if there are early signs and symptoms of heat stroke. Finally, a word of caution at the conclusion of the above discussion. Never leave children in parked vehicles, and never even leave pets in parked vehicles, because due to excessive heat these days, and due to the greenhouse effect, the cars get heated up, and it can have disastrous effect. So never leave children and never leave your pets in parked vehicles. So hope you like this video, and thank you very much for a patient hearing.